Oh, when the saints go marching in. Oh, when the saints go marching in. Oh, Lord, I want to be among the number. Oh, when the saints go marching in.
Hello, our viewers. This is Health Booth Show brought to you by Heaven Bound TV. This is whereby we talk about matters concerning our health. And today I'm privileged to have Dr. Mwathe, who is our guest at our studio today. He's a gynecologist and an obstetrician. And today we are going to discuss about CS. Sometimes when pregnant mothers are due to give birth, they are required to undergo a CS. So we are going to look at what is CS and what are the reasons as per why the women are required to pass through that procedure. I would like to engage you in our talk today, and you can get us through our Facebook fan page, Heaven Bound TV, and also you can get us through WhatsApp and short message, SMS, through the number which is displayed on your screen. So before we start, I would like to invite Daktari to greet you viewers, and then we shall continue from there. Daktari, karibu sana.
Thank you, David, for inviting me to this program in Heaven Bound TV. I hope what we shall discuss will be helpful to our viewers. Yeah.
Karibu sana. Daktari, CS, Caesarian section, what is it generally?
Caesarian section is a transabdominal operation to remove a baby from the mother's uterus. It is the alternative to vaginal delivery. Yes.
Okay. So do we have types of Caesarian section?
Yeah, there's different types. There can be emergency Caesarian section. Emergency Caesarian section means the mother has come expecting a normal delivery, and something has cropped up which will not allow for normal delivery. So the operation done that time is classified as emergency Caesarian section. There are times when the mother has pre-existing conditions or lesions which will not allow for vaginal delivery, and that time we do elective Caesarian section. What we mean by elective Caesarian section is the mother comes, say, the previous day in the evening. She's prepared overnight for the procedure. She is aware what the doctor is going to do the following morning, and the procedure is done when everything is well prepared. Yes.
So these are the two types of Caesarian section.
Yes.
Emergency Caesarian section and the elective one.
Yes.
Yeah. So Daktari, maybe the viewer may like to anataka kujua maybe what are the reasons for this CS or Caesarian section?
There are many indications, and we shall point at them one by one. One of the commonest indications is CPD, or cephalopelvic disproportion. What that one means is the size of the baby's head is bigger than the passage in the pelvis.
Maybe our technician kindly please produce the diagram there. The other one. Yeah.
That one. So the pelvic girdle, the passage, the pelvic girdle is the passage. The baby is a passenger.
It's a passenger.
So when the size of the baby's head is bigger than the passage, where it is supposed to pass through, we call that CPD or cephalopelvic disproportion.
This is the pelvic girdle. This is the passage now.
Yes.
Yeah. So that is what we call cephalopelvic disproportion.
We also can have what we call malposition. The baby, when the baby is presenting by the head is the lowest part, going through that passage. The head enters the pelvis in a transverse position, in that position. When it reaches inside the pelvis, it rotates. So, by the time the baby is born, the baby's face is facing down, is facing towards the anus. But sometimes, during that internal rotation, the head fails to rotate properly, and the face remains facing upwards. Now, when the face is facing outwards, the occiput, or the back of the head, is facing backwards. And that is why we call it occipital posterior position. When the head is in that position, the diameter, which is supposed to pass through that passage we are talking about, is a very large diameter from the chin up to the occiput. And that diameter is far much bigger than when the baby is in the right position. So that malposition is a common indication of Caesarian section being done. But sometimes when the mother's pelvis is big, that mother who has a very wide pelvis can be able to deliver the baby vaginally. But a lot of times you find when it is POPP, the mother will end up by Caesarian section. Yes. The other cause of Caesarian section is malpresentation. When we say presentation, the normal presentation is the head, the lowest part of the baby, in the part in the lowest part of the uterus. So if the head is not presenting, we said when the head is presenting, we call it cephalic presentation. Sometimes it is the other way around. It's the buttocks of the baby which are down there. When the buttocks are presenting, we call it breech presentation. And you see, when it is breech presentation, it can end up with the buttocks are wider. So they will not be able to pass through the pelvic girdle properly. And so if it is breech presentation, sometimes if the pelvis is wide enough, the mother can still be delivered as breech with sometimes complications arising. You can have what we call a foot-ring breech. One foot has passed, but the other one is inside, and the buttocks are still there. When you have a foot-ring breech, you have to save that mother and the baby by Caesarian section. Sometimes you can get shoulder presentation. That time the baby is lying transverse, So the head is on one side or the other side, therefore it is the shoulder, the baby's shoulder, which is presenting. And that one calls for Caesarian section. The other malpresentation, you can have what we call cord presentation. The membranes are not ruptured. You do a vaginal examination. The head probably is presenting, but in front of the head, you feel the cord. When the membranes are not ruptured and you are feeling the cord, we call that cord presentation. When the membranes get ruptured, the cord now prolapses. It passes through the cervix and it will come into the vagina. That one is called cord prolapse. And a lot of times when there is cord prolapse, you can lose the baby. Especially if the cord has come out. The blood vessels in the cord, they shrink. And then the blood supply to the baby is reduced. So that one, there is a lot of baby death when there is cord prolapse.
Our technician, kindly please produce a diagram. Yeah, it's it now.
Yeah, that is what we call cord
presentation.
Cord prolapse. This one has passed.
It has passed through.
Yeah, because the membranes have ruptured. Yeah, that
Uh-huh.
one is very dangerous. Yes. The other indication for Caesarean section is multiple pregnancy. Sometimes you find the mother is carrying twins. She's carrying triplets. When that condition is there, the safe thing to do is to do a Caesarean section. The first baby may be presenting with the head, cephalic presentation. So the doctor can deliver that one easily. The next one may be transverse or it may be breech. And sometimes, even if both were presenting cephalic, after the first baby, now the uterus has a lot of room. You can find the second twin changing the lie. If it was cephalic presentation, it may change. And that is why it is better, in order to save those babies, to do a Caesarean section. The other indication for Caesarean section are medical problems in pregnancy. There is a condition we call PET, or pre-eclamptic toxemia. This one is common in very young girls when they are expectant. It can also occur in those who are above 35. Here you get blood pressure rising very, very high. You find that there is edema, the swelling of the face and the legs. And when you get, you test the urine, you find there is a lot of protein. This PET, or blood pressure rising in pregnancy, it can complicate to eclampsia. Eclampsia means the patient now is convulsing like an epileptic. And when there are those convulsions, you find already the brain of the mother is compromised. The kidneys are compromised. And these patients with eclampsia, and they are taken to theater, you end up with the mother going to ICU. Yes.
Okay, so I think we'll have to take a very short break, but we'll come back soon. We'll be able to continue with the reasons or indications for Caesarian section, and also be able to look at how the mother is prepared for that procedure in case of elective CS. So keep watching us, tutarudi baada ya muda usio mrefu.
When the saints go marching in, oh, when the saints go marching in, oh Lord, I want to be among the number. Oh, when the saints go marching in.
God's favor is unmerited. We will be telling you stories about women of favor or daughters of favor who through their stories have touched many lives. I'll be your host, Rebecca Wangoi, and this is Daughters of Favor. You are highly favored.
Hi everyone, welcome to Let's Listen Together, a program for the young people, and I will be your host, Rachel Waweru.
I'm your host, Miriam Maina. I'm here to walk with you in your journey to purpose.
Hello guys, this is MC Bonte, and I'll be taking you for a hype session each and every Saturday, and above all, never give up.
Clap on the hands, clap on the hands, clap on the hands. Everybody, let's go!
We give you authentic music, inspiring guests,
With amazing topics infused with the Word of God.
in this drive show every Saturday from 10 a.m. to 12:30 p.m. I'm your hype man, Chief Redo.
And I'm the co-host, Laureen Mongai, on Heavenbound TV.
I'll be your DJ Farouk, in charge of music. Let's dance.
Yeah, Igweni. Yeah, Igweni. Yeah, Igweni. We never stop, yes, we keep on praising. The more we do it, man, the fire keep blazing. The fire of such, and it's the fire of blessing. When you need them, no one will see me. A lot of people no one will see me. You need them, no one will see me.
I'm reaching for the highest of heights. No bad man can bring me down. No.
Oh, when the saints go marching in, oh, when the saints go marching in, oh Lord, I want to be among the number. Oh, when the saints go marching in.
Welcome back, our viewers. Remember, we are discussing about Caesarian section with Dr. Mwathe, and we are in indications or reasons as to why women or pregnant women may undergo Caesarian section. So, Daktari, we can continue from where we left.
Okay, thank you. Placenta is usually located in the upper part of the uterus, in the fundus. Sometimes it can be located in the long press. So if you do a scan, ultrasound, and you find the placenta is in front of the presenting part, on the lower part of the uterus, and sometimes it is even covering the cervix, the cervical os. We call that placenta previa. Sometimes the patient can come complaining of abnormal bleeding in pregnancy because the placenta is low-lying. You will be able to detect it when you do an ultrasound. If the lady has got placenta previa and you have detected it before the patient goes in labor, you don't wait for the patient to go in labor. When she reaches 38 weeks, you prepare her for an elective Caesarian section. Placenta previa can have, if it is not treated the right way, the patient can bleed severely if it was not detected in advance. Because usually when the baby is being born, when the cervix has opened, the baby comes out and the placenta is delivered later after the baby. But now, if the placenta is the one preceding the head, it is in front of the head. It means when the cervix opens, it is the placenta which you come out first. And that is associated with very severe bleeding. And that is why if we detect it by ultrasound, we organize for an elective Caesarian section. There is another problem with the uterus which can cause a lot of problems and intrauterine fetal death. The placenta can be in the right place, but during labor, you get uterine contractions. Then, during the process of labor, the placenta separates when the baby is still inside. So, that time, that one we call abruptio placenta. The placenta has separated when the baby is still inside the uterus. If a patient gets a abruptio, there is usually some bleeding and a lot of abdominal pain. And we have to save that mother by doing an emergency Caesarian section. A lot of times you find you have operated, you have been able to save the mother, but because the placenta has separated before the baby has come out, you find a lot of times we lose that baby. So abruptio is an emergency and it causes fetal loss. The other indication is what we call fetal distress. When we say there is fetal distress, what do we mean? It means the baby is under stress. If the baby is not getting enough oxygen, the heart rate of the baby will start going up. It could be due to various reasons, cord around the neck when the baby is still inside. And when we listen to the fetal heart, you find the normal fetal heart is between 120 beats per minute to around 140 beats per minute. So when the child in utero is getting distress, the heartbeat starts going up. When you listen with the gadgets we use, the fetoscope or the Doppler, you find the rate is increasing. If you are listening with the fetoscope, you may find under normal circumstances, the heart is beating like the baby's heart. Do, 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 do. You find the rate is okay, sometimes it is going up, then it is going down. That is when we say the baby is in distress. At the same time, when you do a vaginal examination, the amniotic fluid which is coming out, it changes color from clear to green. Because that time the baby has started passing stool when it is still inside because of the stress. So when you find the amniotic fluid is meconium stained, thick meconium, then you know that child is in danger. It is calling for assistance by emergency Caesarian section. Yes. Now, we are still on indications. If a mother has had a Caesarian section and she conceives again, that calls for a repeat Caesarian section, which is usually elective. Sometimes, say, the first Caesarian section was done because of cord presentation or abnormal eye, not because the pelvis was small. There is what we call trial of scar. Trial of scar, this is a patient who has been operated once, and the operation was not done because of cephalopelvic disproportion. You can allow that woman to go in labor, hoping that the scar on the uterus will not rupture. You have to monitor that patient very closely, and there are dangers of rupture of the uterus. And so you find a lot of doctors opting for elective Caesarian section because of the previous scar. Because the danger of trying the scar is the woman may have all that pain and the baby doesn't come out. So you end up with a Caesarian section. If a complication arises like what I was talking about, rupture of the uterus, you still go to theater to do the CS. If it is ruptured now, you're just opening the abdomen and you go and remove the baby because the uterus has, the scar has given way. And a lot of times when you get that, you are not able to save the baby. And the operation has to be done. So it is usually advisable, if there is a previous Caesarian section, you do an elective Caesarian section. There is also, the uterus can have scars because of different things. This is a patient who has been looking for a baby. There is a time we talked about fibroids, and the operation of myomectomy was done to remove the fibroids. Now this uterus which has had myomectomy, it has a scar here, it has a scar here, and now the mother has conceived. It is usually advisable to do an elective Caesarian section on that patient when she is about 38 weeks. The last indication for Caesarian section, and you have heard about it, there is what we call Caesarian section on request. Some women, they say, I don't want a vaginal delivery. I want a Caesarian section. Because there is a myth, when the baby is being born, the birth canal is damaged or enlarged. And sometimes you see the patient saying, me, I want a Caesarian section. The husband says, I want. It is the duty of the doctor attending that couple to tell them the risks and the complications, because every choice has its own consequences, and the patient has to understand their risks and their consequences, and they should sign for it. Yeah.
Okay. Doctor, you have talked on several reasons as to why the pregnant women can go through CS. Now, in my presentation, you have talked about breech presentation, whereby the presenting parts may be the buttocks or an arm or a foot. Now, in case there is no theater maybe near, can the doctor or a nurse do some maneuvers, mechanical maneuvers, to remove the baby from the uterus?
There before, if the baby was breech, the buttock is the one presenting. We used to do what is called ECV, external cephalic version. You massage the uterus, you turn the baby slowly, 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 until the head is presenting. That procedure, we used to call it ECV. Now there is a danger. This is a bride procedure you are doing. And when you are manually rotating that baby, if the head was up here and the buttocks down there, so that the head comes down, there is a danger of the cord going around the neck. So the doctor will go home very happy. Today I did a successful ECV. 2 weeks later, the mother comes and says, the baby stopped spraying 1 week ago. Because when you are doing that maneuver, the cord went round the neck. So you find nobody wants to do that maneuver now, because it's a bride procedure. It is associated with those problems I'm talking about, cord round the neck, and you find the benefits, the risks outweigh the benefits. So when it is breech, it is better not to do those maneuvers. You just organize for Caesarian section.
Okay. Daktari, the mother has come, the pregnant woman, and you have arranged for elective CS. What are the procedures to be followed in terms of preparing the mother for that procedure of Caesarian section?
When you are preparing the mother, she knows she will go to theater. You have to do a few tests. And a lot of these tests are usually done during the antenatal period. You want to know the hemoglobin or blood level of the mother. You want to know about her HIV status. You want to know whether the kidneys are functioning well, urea and electrolytes. You want to do even the test for syphilis. And the mother has to be explained, and she will sign what we call consent for the Caesarian section.
That she has agreed.
She has agreed. If it is an elective, the mother, you come and she should not take anything by mouth from midnight. Then, about 30 minutes before she is taken to theater, she has to be given what is called pre-medication. And that's that. Theater is prepared, the surgeon is aware, the anesthetist is aware, theater staff, the assisting nurses, everything has been prepared. So everything should go smoothly. Yes.
Wow, that's good. And to make the woman, now the woman has been wheeled to the theater, ready for that procedure, Caesarian section. Tell us about the anesthesia which is administered to make that mother not feel pain or unconscious.
Okay, there are two main types of anesthesia. There is what we call spinal anesthesia. The spinal anesthesia is an injection which is given through the back, at the back. And it paralyzes the mother from the level of the umbilicus downwards. When that drug is given, the mother, even if you pinch her leg, she won't feel. If you pinch the abdomen, she won't feel because she is paralyzed. This type of anesthesia is good because given by somebody who is experienced, it helps in that when you are operating, you are still talking to the patient. When the baby comes out, the mother will hear the baby crying. Before the baby is taken to the nursery or incubator where the baby is being taken, the mother is shown the baby. So you see, yes, this is my baby, it is a boy or it is a girl. She is told how many kilos the baby is. So when you're using spinal anesthesia, there is no hakuna story my baby was exchanged, the baby was born alive, or the baby was born, my baby was not dead. The mother can see. If the baby is born dead, the mother will be shown on the dot. And she is a witness because she is not asleep.
She's not asleep.
The mother will be able to see it is a girl or a boy. Those are advantages. But this anesthesia has its own small problems. Sometimes we have heard somebody was given spinal and after that she was paralyzed. It is because she was given by somebody probably who was incompetent. He gave the injection a little bit too high instead of where it is supposed to be given. So it affected the spinal cord. Are we together? This anesthesia, the patient has to be given a lot of IV fluids. You even start them before you start the procedure. And there is a special, so they have to be well rehydrated. And some patients will complain of a headache post-operatively. So there is some medication the anesthetist you give so that that type of side effect is reduced. The other type of anesthesia is the general anesthesia. This is where you are given a drug through the vein, several combination of drugs. They make the patient to sleep. And now, because you have been paralyzed and you have been made to sleep, you have to be connected to an anesthetic machine. And the machine will help you to breathe. So breathing in, out, it pushes the gases. Because when you're given general anesthesia, you can't breathe on your own. When the patient is given this general anesthesia, there is a tube which is pushed through the mouth to the airway, to the chest, to help push the gases. So this one, if general anesthesia is given, we don't allow that patient to feed for about 24 hours. If you operate in the morning, you start feeding the following morning. But for spinal anesthesia, they are allowed to feed within 6 hours. So you can see the differences.
Now, what makes the difference in terms of the time for feeding, to start feeding?
You know, when you are doing general anesthesia, the systems are paralyzed. So you find the bowel sounds, they take time to come because the intestines are just asleep there. And if you feed them early, that patient, you get a lot of constipation or gas feeding the tummy. Yes.
Okay. And you've talked about the things to do with anesthesia. Now we come to how the incision or the cut is done.
When you are doing a Caesarian section, I wish we would be shown the next
diagram.
We can make what we call a umbilical midline incision. This one is made from on the midline, from below the umbilicus up to the pubic symphysis. That one is a midline, umbilical midline incision. This is what has been done for a very long time. There is another, it is easy to make this one, and this is what used to be done before. Now, there is what we call a phanestoid incision. That is a transverse incision above the pubic crease line. We also call it the bikini incision. If you make a bikini incision, that patient can wear her bikini and go to swim. Nobody will see a scar from the umbilicus downwards. But when you have made a midline, anybody can see
that you have a scar.
So that one is more acceptable, and these days that is what we do. Now, if you are doing a repeat midline incision, previously we used to remove the old scar. Then we proceed with opening the abdomen. When you remove that scar tissue, when you stitch it, it looks very nice. But when you repeat, you have had the first Caesarian section, the second one, some tissue has been removed, the third one, the scar tissue is removed. What happens is that when that woman heals completely, you get a valley on the midline. So you have one abdomen on this side, the other one on this side, and the other one up because of the valley which was created. So these days, if a woman has had a subarachnoid midline, when you are doing a repeat, it is advisable to cut at the center of the previous scar, don't remove the tissue. The stitching, you'll be a little bit hard because of the scar tissue, but when that scar finally heals, it will just be just like the other one. You'll be seeing the woman has one scar, but you'll be no vary which is left there. Yes.
Wow. So our viewers, this is what Daktari was talking about. We have the bikini cut, and we have the midline, which is from the near the umbilicus to the fundus there. Those are the two types of incisions which are used during the CS or Caesarian session. Now, Daktari, coming back to you again about now the incision has been done. Which are these layers which are found?
Okay, there are 5 layers. The patient, you only see the top, the skin. But when you cut the skin, below the skin, there is the fat layer or adipose layer. You cut through that one. Below the fat, there is the fascia or the rectus sheath. It is very tough, and it is one that supports the abdominal muscles. Below the fascia or the rectus sheath, there is the muscle layer. If you are making a longitudinal incision or a suboblique, it is, you just separate the muscles because the muscle layer is below the fascia. If you are making a bikini incision, when you reach the muscle, you don't cut across. You still separate the muscles. You don't cut the muscles as such. Then finally, below that, there is a very thin layer, which we call the peritoneum. So we have the skin, the fat layer, the rectus, the muscle, and the peritoneum. So there are 5 layers. When you have opened the abdomen, either through the bikini or through the midline, now you are seeing the uterus there, and the baby is inside. We normally cut the uterus in a transversely. That is why we call that operation of Caesarian section lower uterine segment Caesarian section or LUST. Lower uterine segment Caesarian section. It is the lower segment of the uterus where we have cut to get into the uterus. When the baby is removed and the placenta is removed and you have cleaned inside the uterus to make sure there are no pieces of membranes which are left there. Now you stitch the uterus, and the uterus is stitched in 3 layers. The muscle layer is stitched twice, and then the serosal, uterine peritoneum. Once you have crossed the uterus, you know the uterus has contracted well, and there is no bleeding, especially at the corners, where you started the incision and where it ended. That is where a lot of times you find bleeding. Once you know the uterus is well contracted, there is no bleeding, you make sure you have not left anything in the abdominal cavity, like gauze or some other things we put there to prevent. Then now you cross the abdomen. Now, when we are opening the abdomen, we start from up. When we are crossing, we start from inside. So the peritoneum, you stitch, it has its own special stitch. From there, the muscle, you may put a few stitches because you have separated just for the muscle to attach. But some people don't even bother crossing the peritoneum. But a lot of doctors believe if God created this part of the body, let's return it the way it was. The fascia or the rectus, there is a special stitch for it. Then the fat layer, there is a special stitch for it. Then the skin. A lot of times when the patient says, I was operated, they only see the skin, the cut on the skin. They don't know you have gone through 5 layers. There's a lot of work being done to put things back the way they were. Yeah.
Okay. Daktari, how many, or what is the number of, the maximum number of CS a woman is supposed to have undergone?
That question is asked by many people. A lot of people feel if you are delivering by Caesarian section, don't go beyond 3. But sometimes you may find a woman underwent a Caesarian section and she lost the baby. That time you can go to the 4th one. Because at least you want at least 3 babies. But you know, why we really try to limit is all these procedures, when they have been done, there are complications which can arise. So you won't tell a woman who is delivering by Caesarian section to go on having 5, 6, 7 babies. If it is a normal delivery and their choice is to get many babies, the risks there are not as high as when the woman was delivering by Caesarian section. So a lot of doctors feel 3 are enough, but if there is a special reason, the 4th one can be done. Yes.
That's very good. What are the complications of Caesarian section?
As we said, everything has its own advantages and complications. One, when you are doing a Caesarian section, there are risks. The blood loss is more than when you are doing a vaginal delivery. So one is hemorrhage.
Loss of blood.
Loss of blood. Number 2, sometimes organs in the abdomen can be injured. You find the bladder has been injured, the intestines have been injured. Those are complications which can occur. Sometimes you find, because the bleeding was so much, somebody forgot an instrument or goes in the abdomen with the complications which you lead that woman to undergo another operation.
To remove it.
The other complication is infection. You have to ensure the things which you are using, the instruments, the whatever materials you are using, they are sterilized properly. And the patient is given the best medication to prevent infection. The other complication is in relation to the anesthesia. We said we have seen cases where spinal anesthesia was used and the patient got paralyzed. You have a patient who has been given general anesthesia, and after that she ends up with going to ICU because she has problem in breathing, she's not waking up properly, and those were problems which probably would not have come if she had a vaginal delivery. And that is why before we go for operation, the patient has to be told there can be complications, but we shall do the best we can so that you don't get them. And that is why the patient gives consent. If you are dealing with a patient who is under 18, the guardian is the one who is supposed to sign the consent, not this girl who is 16, 17. If the patient is under 18, the guardian has to sign the consent. Yes.
Wow, that's good. Now, Dr. I can see our time has far much gone. We'll have to wind up. As we wind up, I know that in your facility you have a very big theater. Maybe you tell the patients about where you come from, your facility, and perhaps if they want to contact you, how they can get you. You give them your numbers.
I'm usually stationed at Diana Hospital. Diana Hospital is along Thika Road at Githurai 45. And I'm there from Monday to Saturday. And my contact is 0722, not 24, 478 897, or 0733 61 61 60. Yes.
0724 47 8897.
Yes.
And then they can also get you through 0733 61 6160. Asante sana daktari. I hope the viewers have benefited from all what we have been talking about, and I'm very much appreciative for taking your time to come to our studios here to educate us. Thank you very much. To our viewers, I thank you for taking your time to watch this show, Health Booth Show, and I'll encourage you to be watching this show every Wednesday so that you can be able to be educated more about matters concerning health. I have been your host, David Ngure. Until next Wednesday, in a time like this, goodbye.